So I've basically been asked, I was asked previously to speak about some treatment options for cocaine dependence. And we were talking in the office about yesterday, and I said it's kind of the strangest talk because really there are none. I said, so it's kind of like you're starting off kind of on a negative. But what we wanted to look at was what has been tried and tested, and what could we maybe look at in the future, you know, what's our promise for, and then maybe some recommendations on what we can do in the meantime around sort of cocaine use. But why are we looking at it now? So obviously we know it's an escalating problem. We're now seeing more people who've been using cocaine for longer and more frequently than we ever have before. So what we're seeing now is cocaine-only users and the physical health problems that they can have. So we're seeing heart attacks, altered heart rhythms, neurological problems, so headaches, seizures, strokes, and we're seeing people now developing GI problems from long-term use. So nausea, severe abdominal pain, those kind of things. We're also seeing the cocaine and heroin users, so they suffer from the same problems as the group above, and they also have their own set of problems that come along with that. There's things like the increased risk of overdose, there's the same sort of risks with polydrug use, and there's also the more frequent injecting. So they consume more heroin than usual, but when the cocaine wears off, they inject again, so they're more prone to overdose, and they can do that unintentionally. They also then have to progress to using more and more cocaine to get the same high, which then increases their risk again of overdose, but also of cardiovascular events. We're also seeing more varied routes of administration problems. We've always seen routes of administration problems with heroin injecting, but now with cocaine, we're seeing smoking, crack cocaine, damaged lungs, and also the worsening of pre-existing conditions at a rate far quicker than would be expected. Snorting, loss of sense of smell, nosebleeds, problems swallowing. Injecting, we see the usual sort of BBV risks, track marks, and bacterial infections. However, these are much more frequent because of the actual number of injections that are being taken throughout the day. I think we were talking kind of 10 to 20 injections a day, if not more, and that, you know, from somebody who's injected heroin maybe 3 or 4 times a day, that's a massive increase and a massive increase in risk. So when we move on to, obviously we live in Scotland, so alcohol plays a big part in everything, but cocaine and alcohol, we produce cocaethylene. 21 times more likely to die if you have a pre-existing heart condition and you use both cocaine and alcohol. Cocaethylene has a longer half-life than cocaine, so you have a much longer exposure to the effects and therefore any bad side effects that you've got. There's the recent government campaigns to highlight the risks to recreational users. Cocaine's always been used recreationally, but I don't think anyone has ever appreciated the sort of severe risks that come with it. Studies that look at the treatment for concurrent problems with alcohol and cocaine primarily focus on disulfiram and naltrexone. We'll touch on that a bit later, but for that specific problem, more, I would say, of recreational users where the uses get out of hand, that's the two sort of treatments of choice. General risks with cocaine use is binging, so people maybe go on a bender, repeated use in a short space of time, increase in doses, and obviously the longer that goes on, the greater their risk of overdose. Obviously then you have the issues with nasal passages and things like that from that increased use over such a short space of time. So what do we kind of look at when we want to look at treatments for cocaine use? So cocaine acts on the mesolimbic system in the brain, so that's the reward pathway. Don't worry, I won't get too technical because this is about as far as my knowledge goes as well. So what we're looking at is things that would actually modulate the dopamine in that system, which gives it the pleasurable effects and that sort of reward that people want when they use cocaine. So currently psychosocial interventions are the mainstay of treatment, but obviously ideally we live in a society where we want to take a pill that fixes everything. And obviously drug companies are desperate to find a pharmacological treatment that would help with this. So the main focus is any drug, and by that I mean any drug that affects dopamine in the brain will have been tried and tested. So what happens is when you take cocaine, the dopamine is not reabsorbed by the body, so it sits in the receptor synapse and causes a pleasurable effect. That means that the levels of dopamine in the brain are depleted, so when that effect wears off, you want to take more. So if we can get a drug that would work to sort of alleviate the effects of that depletion of the dopamine, then theoretically, we should be able to stop people wanting to then carry on and use more cocaine. But unfortunately, the reality is that is very difficult to achieve, as with anything that works on the brain is. So we'll now give you a bit of an idea of the sort of breadth of drugs that have been tried for this treatment. So this is some of them. So they've tried anticonvulsants, obviously normally used to stop seizures, antidepressants, sertraline, varenicline are two. Varenicline is typically used as a smoking cessation tool, but obviously it affects dopamine in the brain, therefore why wouldn't it work for cocaine? It's probably one of the more logical ones if you think, well, if it stops people wanting to smoke, then if it affects those kind of systems in the brain, then surely it would work for something else. And manufacturers are more and more looking to existing drugs to find new ways to use them at different doses. We only have to look at things like Viagra, which is now used for blood pressure, and other things, obviously. But they want tried and tested drugs because they don't have to worry about side effect profiles and things like that. And the majority of the testing has already been done, so all they need to do is prove it works. And it's obviously far better for them. So we are looking for existing drugs to try and find new ways to use them. Antipsychotics, anticholinesterase inhibitors, alpha blockers, so things that are typically used for blood pressure, heart problems, all those kind of things, all work in the dopamine system in the brain, and obviously they hope would work with cocaine addiction. Other groups, dopamine agonists, CNS stimulants, obviously the treatments for alcohol dependence. If it works for one type of dependence, would it work for another type? So they want to try those things. Symptomatic relief, obviously they've tried trials where they just give patients symptomatic relief, and things like propranolol, which help them just feel a bit better. And then there's N-acetylcysteine, which is one that is normally used to treat paracetamol overdose. That's been tried as well. So the Cochrane group who do sort of studies and systematic reviews on drugs have carried out no less than 6 large reviews on the drugs that have been tried. And that's things like meta-analysis, statistical analysis, individual studies, grouping them all together, looking to see if the different drugs different studies combined could prove one thing or another. And unfortunately, that they have been unable to find any conclusive evidence that any of these treatments are actually effective. If we look at N-acetylcysteine, there's been 6 trials, but the biggest one of them had 110 patients, and the next one only had 23. Most of the results were based on patients reporting of cravings being reduced. So it's very subjective, and it's very difficult to get patients to be completely honest, or they might believe that their cravings are reduced, but is it partly placebo? Is it partly because you're asking them? Is it, it's very difficult to get to the bottom of it. And a lot of these studies measured totally different things. So some measured the number of days they used cocaine, some measured the spend, how much they actually spent on cocaine, some measured abstinence, and some measured reduction in cravings. So you've got 6 trials, some had 5 patients, all measuring different things, and not one of them could conclusively say that this product worked. So you can see how difficult it is to actually then get medication to be accepted on an evidence base when that's the sort of things you're faced with. And the trials that are being carried out, unfortunately, would not be classed as evidence-based. So if we look at all those studies together, the EMCDD, which is the European Drug Centre, they tested thousands of patients, thousands of studies and articles have been published, and the EMCDD believe that antipsychotics show the most promise as treatment options. They believe that disulfiram is the most accepted by patients, but they have also stated there is no accepted effective pharmacological treatment. Psychosocial interventions, in their view, are the only ones that have been shown to be effective. But obviously, it's very difficult to get patients to take part in psychosocial interventions. It's very difficult to get them spaces on treatment programmes, and it's very difficult to get them to complete them. Blanken, I think it's Peter Blanken, is an expert in cocaine treatment, and he's had multiple publications and was part of the group of experts who carried out the 6 Cochrane reviews. And he works with the ECMDDA, and his studies focus around the use of stimulants, so things like methylphenidate, to treat cocaine addiction. And he believes that that's where the most promise lies. So on one hand, you've got a European body who are saying antipsychotics, and on the other hand, you've got a world-renowned expert who's saying there's promising indications for stimulants. So again, we're faced with this conflict of not really knowing where to go. Nobody really knows which direction is the best to follow, and as we all know, studies in these things cost vast amounts of money, so it's very difficult to know which direction to go in. Ideally, we'd like to test them both, but that might not be possible. So what we're looking for is, if we look further just at sort of other studies that maybe weren't included in the Cochrane reviews, again, more information and more studies which looked at stimulant treatment and which were very promising. But again, and there's obviously a number of studies which showed just sort of random drugs that didn't really fit into any particular group. Again, most relied on patient-reported use of cravings, feelings, decreased use reported. So again, very subjective. It's very difficult when you're studying this sort of this kind of thing to get a sort of conclusive result. And again, when it comes to then treatment, it makes it very difficult to get this treatment accepted. The quality of the studies is very variable as well. They sort of varied from double-blind to, we'll just give them this tablet and then ask them how they feel a week later, which obviously is not great. And as I said, most rely on patient reporting of use. So I felt a bit downhearted or disheartened when I kind of came to the end of all that review, and I thought, well, really, there's nothing promising there at all. So I went to one of the psychologists who works in our service and asked her what she would have recommended, and she said, from their point of view, there is actually a multitude of things that they can do with patients. So that gave me a bit of a lift. I felt a bit better after that. So things like motivational interviewing, contingency management, she said even things such as community reinforcement approaches, which are more an American type of thing, which involves the patient's whole community and involves reward schemes, vouchers, that kind of thing. Obviously, one of the mainstays of our treatment is cognitive behavioural therapy, very labour intensive. Patients can require long courses, but it does work. And they would also consider cognitive behavioural therapy, which deals with complex problems. So they would deal with any trauma that had led to the drug misuse in the first place. And one thing that she said actually can work very well with cocaine use is behavioural couples therapy, particularly if one person in the partnership doesn't use cocaine and the other person does, then that can be quite beneficial. Community reinforcement, continuity management is the American one, and community reinforcement is a type of learning which it aims to sort of reprogram people to believe that healthy living is a rewarding way to live, and it kind of reinforces that. So once I had kind of been buoyed up by the psychologist input, we were to come up with some recommendations. But first and foremost, what we need to make sure is that any care is patient-centred and it's individualised. Patients need to have that holistic approach. We need to ask them about everything that they're doing, their lifestyle. And I think when it comes to cocaine use, lifestyle is obviously massively important. Urine screens, what we sort of just talking to people that worked in some of the teams, use the urine screens as kind of, you know, the all-seeing eye. If it doesn't show up in the urine screen, it doesn't exist, therefore I don't have to mention it. It'll only show up for 4 days, so if the patient knows they're coming for a urine screen, chances are they won't use before that, and then they'll show up, get a clean screen. So what we were suggesting is just ask. I do some of the work with the university, and when we're training some of the pharmacist prescribers, a lot of them will say, so how are you getting on with things? Have you been using anything you shouldn't have? And in their feedback, I'll always say to them, you didn't ask them if they were using heroin, you didn't ask them if they were injecting, you didn't ask them if they were using cocaine. And some of them are quite shocked, well, I don't want to just come right out and say it, you know, they might be offended. And I was like, well, you need to be that upfront and honest. When you're dealing with this subject, patients will respect that honesty and bluntness far more than they will you skirting around the issue. So ask if they've used anything. You'll 9 times out of 10 you'll get an honest answer. Obviously a bit of harm reduction, so are they snorting or injecting cocaine? If they're injecting, there's additional considerations that will have to be made. They will require more frequent injections, so don't shy away about supplying more kits for them to do that. They'll be more likely to use their kits more than once because they don't want to ask for 20 kits when they're in the pharmacy or the injecting equipment provision provider. So offer that, and it will mean that they more than likely will take it. If they are sharing or reusing their needles, then more risk of BBV. So educate on safe injecting practices. Vitally important if somebody's injecting 20 times a day to make sure that they're doing it properly to limit the damage that they're going to do. If you're increasing your number of injecting times that much, the chances are you're not going to have very many veins left after a short period of time. So if you can encourage them to do it properly and show them how to do it properly, then there's a bit of benefit from that. With cocaine use, I think it's vital that there is that sort of holistic approach. Cocaine is an expensive habit, so debt can be a major problem, and it can also be a major barrier to recovery. They get themselves into a situation where they can't get out. So it's important to ask about that. Psychosocial is again important to find out the reason why something's being used as opposed to focusing actually on the substance being used. Ask them if they would be interested in any kind of psychosocial help. And ensure appropriate referrals. Make staff aware of any inclusion or exclusion criteria so they're not inappropriately referring somebody for help who will then be refused, because that's the biggest off-put for patients. And ensure staff are educated. That can be a major barrier to patients accessing the correct treatment, and it's obviously vital to ensuring that patients get what they need to help. So I hope that's not been too depressing a talk. Basically there are no treatments, but I hope you can see that there's a lot of work being done. You know, there is a lot of drug companies are trying to find a drug that works, and you know, studies are being done by researchers to try and find drugs that work. It's just that at the moment they're not quite there yet. I've got no doubt they will get there and they'll find something that is quite effective. But in the meantime, I think it's really beneficial to take note of the variety of psychosocial inputs that can be made in your service and ensure that patients are being referred to them. The psychologist actually said to me, we can't help people if we don't know they exist. And people sometimes say to us, oh, I had a patient and they couldn't get into psych. The wait time for psychology is just horrendous. Well, you don't know till you've referred them and found out how long they're going to have to wait. She said, so we don't know. If we don't know about them, we can't treat them, we can't plan, we can't get more psychologists in to help. So you need to refer them and take it from there. But no, I think that's... Yeah, any questions? Not too hard, please.